Dear audience, let me present my research about antibiotic prophylaxis for ERCP. My name is Kálmán Zsigmond and I work as a medical doctor at the Military Hospital of Budapest. My vision is to increase the safety of ERCP procedures, and in order to achieve that, I would like to perform research to understand how to prepare the patients properly for ERCP procedure in order to decrease the rate of complications. We have two ongoing projects. The first is assessing the topic of antibiotic prophylaxis via systematic review and meta-analysis. The second one will be a study protocol for a randomized controlled trial in this topic. The first project is investigating the safety and effectiveness of antibiotic prophylaxis for ERCP. ERCP is a high-risk procedure which can have several complications. One of them is being infections, especially cholangitis, which is the third most common complication of the procedure. It can have quite severe consequences as its mortality can reach up to 10%. By current guidelines, antibiotic prophylaxis is only recommended for patients who are at high risk for infections, and it is not recommended routinely before every ERCP procedure. However, the data here remains controversial. Our aim is to investigate the significance of antibiotic prophylaxis for ERCP. The clinical question is, does antibiotic prophylaxis decrease the infection rate after ERCP? We use the PICO framework, the intervention being antibiotic prophylaxis compared to no antibiotic. Our hypothesis is that antibiotic prophylaxis decreases the risk of infection. We conducted our search in 5 databases. We ended up with 5,600 results, which were narrowed down to 14 eligible full-text articles. After the data extraction and the booster project with the statisticians, we have our outcomes represented as forest plots. So let me guide you through them. The first outcome, our main outcome, is cholangitis after ERCP, which is the most important infective complication of the procedure. We have 2 groups. Here you can see the antibiotic group and the no antibiotic group. The event number shows the number of cholangitis in each group after the ERCP procedure. We have 11 studies which are all randomized controlled trials with these 2 arms and roughly around 2,000 patients. The I2 square shows a moderate heterogeneity, which means the study population are fairly comparable, and the results are shown as risk ratios, which is 0.6. which means that by using antibiotic prophylaxis, we can decrease the risk of cholangitis after ERCP by 40%, which is clinically quite relevant, as by decreasing the rate of cholangitis, we can decrease the rate of complication arising from the infection. However, this does not reach statistical significance, mathematical significance, which can be due to the maybe the heterogeneity of the population, the different antibiotics which are used, and the lack of data which the authors gave us in some of the randomized controlled trials. However, the results show that there may be a benefit for the use of antibiotic prophylaxis, and our next step will be to deep dive into the data and try to find a specific population which benefits the most from the prophylaxis. The next outcome is sepsis, which is really relevant clinically, as a mild form of sepsis can have a 10% early in hospital mortality rate. And the logic of the first plot is the same. We have the antibiotic and the no antibiotic group. Here we have 5 randomized controlled trials with 900 patients. And the I2 square shows a low heterogeneity, but with a high confidence interval. The risk ratio is 0.63, which means that by using antibiotic prophylaxis, we can decrease the risk of sepsis by 37%, which is clinically highly relevant, as we can further reduce the chance of sepsis. We can reduce mortality too. But it does not reach clinical significance. However, it shows that may be a benefit of antibiotic prophylaxis. Our strengths are that we analyze randomized controlled trials, aiming for the highest level of evidence, and we have quite a large number of patients. This is the largest meta-analysis done in this topic. However, we have some limitation that the studies are 25, the majority of the studies are 25, 30 years old, and it has been a change in the technology and the indication even of the ERCP procedure. And some of the authors really gave us limited data about their population, so we cannot do sometimes detailed subgroup analysis. Our conclusion is that antibiotic prophylaxis may reduce the risk of cholangitis and sepsis after ERCP, and we would advise the clinicians to consider using antibiotic prophylaxis, especially for certain population, which is an implication for research to identify the risk groups who really do benefit from the antibiotic prophylaxis. Here you can see our progress, and we are moving on with the risk of bias assessment. Our next project is investigating the effectiveness of antibiotic prophylaxis in patients with biliary obstruction undergoing ERCP. So, as I've told you, post-ERCP cholangitis is an important complication of the procedure, and ERCP's main indication is the biliary obstruction. As you can see on the picture too, the bile duct is obstructed either by a benign cause, for example, biliary duct stones or malignancy, pancreatic cancer or cholangiocarcinoma. However, the indication of the procedure changed through time. In the early 90s, 2000s, ERCP was used as a diagnostic tool too, not just a therapeutic tool. But nowadays, it's safe just as a therapy, as an invasive procedure with complications. For a diagnosis, we have better tools like endoscopic ultrasound, MRI, and CT scan. And our meta-analysis show that there may be a benefit for antibiotic prophylaxis. However, the RCTs came from this era with a broader spectrum of the indication of the ERCP. So we aim to investigate the significance of antibiotic prophylaxis for ERCP in patients with a clear indication for ERCP with biliary obstruction. We are drafting our protocol. We would like to include adult patients with biliary obstruction proven by abdominal ultrasound, CT, MRI, or EUS. And we would exclude patients who got previous antibiotic within 1 week, show sign of cholangitis, had undergone previous ERCP with sphincterectomy, are pregnant or allergic to the chosen antibiotic. So after preparing our protocol, we will move on with the statisticians to the sample size calculation and proceed after that. In summary, we would like to finish our first project this September, and after that year in autumn, we would like to finish our second project too. I would like to close with the words of Abraham Lincoln, that leave nothing for tomorrow which can be done today. Thank you very much for your attention.
Thank you for your presentation. I have one question. Do you find anything in the literature? What is the time if you use antibiotic before the ERCP? How many days should we start the antibiotic before the ERCP?
It's a one-time prophylaxis.
As a prophylaxis, yes.
Yes, it's a one-time prophylaxis, mainly parenteral intravenously, and it was given 30 minutes, mostly in the Morse RCT, 30 minutes before the procedure. Yes. One RCT is with a prolonged prophylaxis, that they continued the prophylaxis after the ERCP too, but the majority of them, it was just one shot.
Thank you. I have another short question if there is nothing in the audience. Do you know what type of antibioticum?
It changes.
Should we use?
Yes, I cannot tell you exactly because it really changes.
It changes. Okay.
It changes based on the resistance profile of the bacteria which causes cholangitis in each hospital. Yes.
Congratulations, excellent presentation and very hot topic. Do you have any subgroups in this case when the patient, for example, has a tumor of indicated obstruction biliary, for example 500 bilirubin level, and the patient used the clopidogrel. And I need to stop the clopidogrel treatment, and after that I need to perform the ERCP, but until like bridging antibiotic therapy until the ERCP. Do you have any data about this? I need to give for this patient the antibiotic therapy or no? Thank you.
Thank you. So, regarding your first part of the question, which was, can you help me?
This was one question.
Okay, just a clopidogrel, the malignancy. Yes, so really just a few articles are giving us information about malignancy and antibiotic prophylaxis. Only one article gives us the exact numbers that they have seen a reduction in infections with giving antibiotic prophylaxis, but they did not reach a statistical significance there, only a tendency for that. And regarding the clopidogrel and bridging, I haven't seen anything like this in this.
Regarding for your first project, the sepsis was due to the cholangitis, or do you have any data that it was maybe just the bacteremia and it was, for example, endocarditis, septic arthritis?
Yes, it's like related in the articles. It is suggested that it's due to the cholangitis. Yes, the logic is built up like this.
Okay, thank you so much.
Kálmán, have you performed subgroup analysis based on the risk of bias assessment? Or did you check the sensitivity analysis if that would change your overall risk ratio for the cholangitis?
We haven't finished the risk of bias assessment yet, so I cannot tell you that. But we have done like leave one out analysis. And there is one article which is kind of it's not mathematically an outlier, but it has colliding data, and if we leave that out, we are reaching mathematical significance to that. So we are looking into the article, maybe reaching out to the authors to have more information what happened there.
All right, yeah. So after the risk of bias, I think carefully do the risk of bias for that article, and maybe you can do the subgroup analysis based on that.